بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد أشرف المرسلين وعلى آله وصحبه أجمعين. Welcome all for the first Merck Southern Region Oncology Club meeting. This is virtual meeting, and this is the first educational activity supported by Merck covering the colorectal cancer. Today we have Dr. Amjad Rahman, Consultant Medical Oncology at Asir Central Hospital, and also we have Dr. Waleed Alselwi, Consultant Medical Oncology at King Fahd Specialist Hospital, Dammam. And we thank Merck for sponsoring this education activity and welcome you all, starting with the first topic, trying to cover the metastatic colorectal cancer, the first line, and discussing the evidence. Our talk The outline of our talk is to cover the size of the problem called metastatic colorectal cancer and also the treatment choice and the role of the biomarkers. Then we'll discuss also the overall survival data we have from the clinical trials and the first line options. Then we'll tackle the wide RAS options. Then we'll try to discuss the combination of FOLFOX and cetuximab evidence. We'll cover also the role of anti-EGFR when cytoreduction is the goal in the right side colorectal cancer. Also, we'll tackle the anti-BRAF approach and the maintenance therapy, and we'll conclude by the Nccn Guidelines and the take-home message. The size of the problem, all of us know that the colorectal cancer comes in the second position in Saudi Arabia. This is based on 2015 data, and it constitutes about 12.2% of the cancers in the second position in general. And when it comes to the gender, we can see that it is the first one among males, constitute about 15% of the cancers, while in females comes in the third position, almost affecting or 10% of the female cancers. The staging-wise, we can see that we are still seeing a good percentage of metastatic cancer. We have in the almost third of the cases of metastatic of colorectal cancer coming as distant metastasis, while around 40% regional, while 26% are localized. So how to optimize the treatment of colorectal cancer? We have to know, first of all, that colon cancer is not one disease. It is almost now very complicated disease, and we have, in order to optimize and to separate and dissect the cases, we have to consider many factors, including the tumor burden. That means the resectability of the tumor. Is it resectable or not? This is the first point. And if it is resectable or potentially resectable or unresectable, then for unresectable, we have to see if it is high burden tumor or oligometastasis, that means low burden tumor. Then we have also to consider the patient performance status, fit patient or not fit, frail, elderly patient, and thereafter coming the role of the biomarkers. For the biomarkers, it is mandatory to do the fourth line setting, at least the RAS mutation testing, BRAF, MSI. And in the later lines, you have also to consider doing the HER2/neu, NTRK, ROS, and ALK. And the tumor location is very important. Sidedness is very important, either left or right side. So we have the known biomarkers for the molecular testing. We know that we have around 50 to 55% of the colorectal cancer is RAS mutated, while we have 45% to 50% wild type, and we have also coming also the BRAF mutated cases around 10%, while for microsatellite instability high patient around 5% of the cases. So for the mutant KRAS cases, usually we use the backbone FOLFOX and FOLFIRI and bevacizumab as a vascular endothelial growth factor antibody. While for the patient with RAS wild molecular entity, we usually treat them with either. We have more options either to treat them with the EGFR antibody or vascular endothelial growth factor antibody. And we have the BRAF that we have to consider the use of more aggressive treatment for BRAF cases using FOLFOXIRI plus bevacizumab, or in the second line setting we can consider using the cetuximab in encorafenib. And for MSI high, we are using, as you know, the immune checkpoint inhibitors. So the sidedness is very important, and we know that the behavior of disease and the predictive value of this sidedness is important. For the right side, we are talking about very different disease in comparison with the left side. We can use, in this case, triplet chemotherapy with BIF or encorafenib with cetuximab or anti-PD-L1, depending on the molecular status, while for the left side we have more chance of wild type and mutated cancer, so we can use the anti-EGFR, and at certain stage we can use the HER2 status therapy based on the positivity of the HER2. And it is now the luxury of so many options, and it is matter how do we personalize the therapy. So we have many options. We started by 5FU. Now we have the capecitabine, irinotecan, oxal, BIF, cetuximab, regorafenib, aflibercept, and panitumumab, TAS, ramucirumab, and we end with BIS supportive care. So either to use tribe approach by using FOLFOXIRI, or to consider the use of a crystal approach, the usual FOLFIRI, cetuximab, or the other approach is using Zelux-based therapy. So we have now many options that we have to consider. So based on that, we achieved better overall survival, and we can see that there is proportional impact on magnitude of overall survival benefited achieved across lines of therapy. So across all the lines, despite that we are reaching to the third and fourth line, still we have very excellent hazard ratio. We can see the hazard ratio by using the first line and with achieving overall survival in the first line up to 4.2 months, and in the second line 2.1, and the third line 1.4 to 1.8, but we have very nice, very impressive hazard ratio. If we can see in the fourth line reaching up to 0.68, that means a lot of patients can benefit from across all the lines. So the improvement of the overall survival clearly reflected by the addition of the target agents, and we can see that we gained now almost in the median overall survival up to 30 to 40 months by the addition of targeted therapy. So the use of targeted therapy is very crucial in the treatment of first-line metastatic colorectal cancer. And we can see that we have to use all of our guns in this first line, because when we end up with the fourth line, only 13% of the metastatic colorectal cancer patient reach to us, 13% only. So while in the second line we can catch up to 53%, in the third line 28%. So treatment in the first line matters because the number of patients diminishes from line to line. And this is again the hazard ratio. Clearly we can see that the median survival increase over lines, and this what message we can get from this diagram, that patient should be exposed to all active and approved agents during treatment, because still we have very nice median overall survival in if we compare, and it is not over survival, of course, and it is the mirror of it is the hazard ratio. We can see very nice hazard ratio across the lines. It is 0.36 almost, with significant p-value in the third line. And we can clearly see from the meta-analysis by the introduction of after the CLGB trial, we can see that we achieved a lot by the using of the targeted therapy, and this is the separation of the curve, discriminating between the stage of chemo-only stage versus targeted therapy stage. We can see very impressive separation of the curve. This is up to the meta-analysis 1992, and now we are getting better and better results. So we are now talking about almost overall survival 32 months among patients with metastatic colorectal cancer. We can achieve up to 5 months in the first line from the induction, then maintenance 6 months, reintroduction 3 months. If we move to the second line 4 months, then we third line 3 months, salvage we can gain also from at 3 months. So we end up by 32 months and more. So what we'll do for the how to optimize the treatment, we have for the wild RAS options, we have clear data that for wild type we have to use anti-EGFR, and we can clearly get the answer from the FIRE3, from the PEAK trial, from the CLGB SWAG. Clearly by this curve we can see almost from the forest plot curve clear benefit, overall benefit with significant p-value by the use of in favor of anti-EGFR, all of them in favor of the use of EGFR versus the anti-phosphorylated growth factors. When it comes to the hazard ratio for the KRAS wild type, the same as we saw in the intention to treat previously, we can see across all the lines that we did not lose the hazard ratio. We did not lose the progression-free survival. We can see clearly in the first line from the Nordic trial, Cohen trial, Prime, Crystal, all of them showing us good hazard ratio. When it comes to the second line, we are gaining from EPIC and 1H1 study, again, good hazard ratio. Even when we reach to the salvage, still the hazard ratio is maintained and improving. So don't leave your patient without treatment if the performance status is good. So what about the combination of FOLFOX and cetuximab? Many questions are raised regarding this combination, but we have clear answer coming from the Taylor trial, which randomized the patient and treated KRAS patient. We have around 400 patients in this phase 3 trial, multi-center and treated patient, either to use FOLFOX cetuximab versus FOLFOX alone. And we can see clearly that the primary endpoint met, and we have progression-free survival is significantly improved with the addition of cetuximab to FOLFOX with hazard ratio of 0.69, and simply we can combine with very nice and significant progression-free survival and hazard ratio of the combination of FOLFOX with the cetuximab. So in summary, just because we have previous data from OBAS study that we don't have a clear overall survival from the OBAS trial by the combination of cetuximab with FOLFOX, and this one was attributed to the small small subgroup of KRAS patient. So we did, and the study was not empowered to achieve survival difference, while clearly now from the Taylor study, we have significantly increased progression-free survival, overall response rate when treated patient with cetuximab plus FOLFOX versus FOLFOX alone. So, and this one also again reflected by the CLGB SWAG trial, which showed and supported the effect of the first line combination of either cetuximab with FOLFOX or bevacizumab with FOLFOX. And again, this combination was comparable, supporting again the possibility of combining the FOLFOX with cetuximab as acceptable and excellent combination. What about the role of anti-EGFR in the right side when cytoreduction is the goal? Because we have a lot of talk about the benefit of anti-EGFR on the right side, and sometimes we have cytoreduction or downstaging is our target or our goal. So we have a clear answer from Wang meta-analysis, and the Wang meta-analysis summarized the results of the Crystal, Prime, and Taylor trials and another trial, which around we have 4 trials, and we can see clearly in this forest plot curve that in the right side, when the cytoreduction is a goal, and the KRAS wild type, there is clear benefit from using either FOLFIRI cetuximab or using cetuximab with FOLFOX, and the clearly summation or most of this meta-analysis clearly showed significant benefit and overall response rate for the anti-EGFR plus chemotherapy versus chemotherapy alone in terms of overall survival. The same data also reproduced from the Taylor study, which also confirmed again clearly on the right side, KRAS wild type, that we have very impressive not only response rate, but also we have response rate, overall survival, and this survival benefit was maintained up to 3 years by the combination of the cetuximab with FOLFOX or FOLFIRI on the right side wild type colon cancer. And this results also can be seen also in the FIRE and CLGB trial. We can see clearly also the benefit is maintained with significant hazard ratio. So now we have clear answer that when our goal is to achieve cytoreduction and we are aiming for good response rate, using of cetuximab with backbone chemotherapy is a good option on the right side. So what is the effect of sidedness, right versus left metastatic colorectal cancer? As we mentioned before, that the sidedness means a lot, and we can see clearly from CLGB SWAG very clear data reflecting the importance of the sidedness. And we see that from CLGB SWAG that the overall survival in both arms, either chemo, cetuximab, or bevacizumab in general, no difference. But when it comes to the prognostic part of the sidedness on the overall survival, we can see clear separation of the curve. So we can see very impressive benefit. We have median survival 33 months on the left side, while on the right side we have almost 19% only median survival. This reflects that the sidedness means a lot when it comes to the RAS. First of all, in general now, this one, either RAS mutated or unmutated, the left side has poor prognosis, the right side has poor prognosis in comparison with the left side with the very impressive p-value. And we can see now what is the effect, what is the predictive value of the sidedness by the use based on the RAS status. we can see clearly that it has very important predictive value. And this study changed the practice. And from that study, and now we are considering that the left-sided, it has the best response to the use of anti-EGFR. And we can see the separation of the curve. This is the pinkish one is the left-sided using the cetuximab. We have the best of the best responses, while when it comes to the right side, we have lowest. We can compare 40 months for the left side with cetuximab with 25.4 and the right-sided KRAS wild type. So the sidedness, it has very crucial predictive value. And when we separate these cases based on the use of bevacizumab or cetuximab, based on the RAS wild type or mutated, we can see that bevacizumab on the right side, the curve narrower than when we use the target anti-EGFR in patient with RAS wild type. We have very nice separation of the curve, supporting the importance of the use of cetuximab in the proper place and the proper site. Left-sided, we can gain almost 36 months in comparison with only 16 months if we use it on the right side. So, and this again, from the we can see it diagrammatically. We can see that we are gaining from the ACL and the left side tumors by the superiority of cetuximab. It is almost 40 months by use of cetuximab with the backbone chemotherapy, while 32 months for the bevacizumab. We have delta of 6.7 months with hazard ratio of 0.77. That means it is clearly, in this phase 3 CLGB, clearly beneficial to use the cetuximab or the anti-EGFR in general in the left side for the wild type. And this result also reproduced in the FIRE3, the same result also supporting our impression. We reached it up to delta of 10.3 months with very nice hazard ratios 0.63 and p-value 0.002 by the use of cetuximab in the left side in the wild type metastatic colorectal cancer. So for the left-sided, of course, if we have wild type, we have to use doublet with the anti-EGFR. If mutated, we use doublet and anti-vascular endothelial growth factor. While for the right, we have to find, we have to only limited option to use anti-vascular endothelial growth factor, unless if we have the cytoreduction is a concern for us. The triplet also is an option on the right side. What about the microsatellite instability, high microsatellite in metastatic colorectal cancer? We have this ASCO 2020 very nice answer about this regard and very nice data when they compared the pembrolizumab Q3 weeks versus the investigator choice chemotherapy, either FOLFOX or with bevacizumab or FOLFOX with cetuximab or FOLFIRI or whatever the choice. We can see very nice progression-free survival. Now, this is the first time talking about chemo-free protocol, and we have progression-free survival of 54% for Pembro. The events in the Pembro almost 54%, while in the chemo 73% with very nice hazard ratio, and we have sustainable response. And this is the nice thing about immune therapy, that we have almost durable response. And we can see that as usual for the separation of the curve, usually the chemotherapy, it showed some superiority in the initial few 3 months, but later on we can see that the superiority of the pembrolizumab in the response and the durability of it. And we can see here clearly that despite of the good results which we have in terms of overall response rate, which we achieved almost 43% response rate in comparison with only 33% with chemotherapy. But the strange thing that we have still unmet need reflected by the progressive disease, which we found in the pembrolizumab arm. 30% of the patient, they progress, while in the chemotherapy only 12.3 of the cases progress, reflecting that we have heterogeneous group of the patient among MSI that should be traced and studied in the next upcoming trials. And we can see here the depth of the response, very deep response for the pembrolizumab versus the chemotherapy, and the duration, as we mentioned, of the response. So it is non-reached for the immune therapy, while for the chemotherapy we reach it to 10.6 months. And the side effects almost are comparable, and we can see that most of the side effects for pembrolizumab are 3, and almost the cause of this, or there is 0 death among both arms. So we concluded from this pembrolizumab use in the treatment of MSI high metastatic colorectal cancer that pembrolizumab should be a new standard of care and as the first-line therapy in patients with microsatellite instability, as it showed clinically meaningful and statistically significant improvement in progression-free survival versus chemotherapy in patients with microsatellite high metastatic colorectal cancer, with the median progression-free survival 16.5 versus 8.2, with the very impressive hazard ratio and p-value, and the response were more durable with pembro versus chemo. And we are waiting for survival data in the upcoming few months. And we have another option from Checkmate 142 also regarding the use of nivolumab, ipilimumab also. In this case, we can see also this is, the number of the sample size in this trial is smaller than what we have in Pembro, and we have initial data from Checkmate that also we can achieve progression-free survival reaching up to 76% by the use of Nivo AB and for microsatellite instability high cases. So we added now to the management paradigm of the metastatic colorectal cancer that if we have MSI high cases, or we can use pembrolizumab or nivolumab, ipilimumab as an option. For microsatellite stable, if we have for the left side, we are adopting almost the same protocol as the other cases. What about the anti-BRAF? We know that we have around 8 to 10% of the metastatic colorectal cancer, they are BRAF mutated, and there is unmet need for dealing with these very refractory cases of metastatic colorectal cancer. We have some data from the trial which used fulfoxiri bifacizumab versus fulfiri bifacizumab in the first line setting, and we can see that the fulfoxiri bifacizumab win, and we have clear progression-free survival in the intention to treat population by the use of the triplet therapy, and almost all of the patients get benefit in favor of the use of triplet therapy, including those patients with BRAF mutation. So, and when it comes to the overall survival, also we have overall survival benefit with hazard ratio of 0.8 by the use of the triplet versus the doublet. And when it comes to the response rate, we have clear superiority of the triplet over the doublet. We have, with significant p-value, we have 65% response rate by the use of triplet in the intention to treat population. And it is reflected also here clearly, both in the radical intent surgery or for the possibility of resection of metastasis, both for the patient with intention to treat population and patient with liver limited disease. We can see clearly that we achieved a good response by the use of the BIF folfoxiri for downstaging of these cases in order to achieve R0 surgery in patients with, in general, and in the liver-limited disease. So based on that, we can say that this randomized phase 3 trial, TRIBE trial, demonstrates significant increase in overall survival, progression and overall survival with BIF folfoxiri versus BIF folpiri. And the median overall survival, it is almost 30 months by the use of triplet versus 26 months by the use of doublet. And also we have clear progression-free survival and superior overall response rate. And the benefit of folfoxiri plus BIF was independent of RAS or BRAF mutational status. We know that the BRAF V600E has predictive value in for the response to certain treatment, and we have almost we have some data that the use of dabrafenib, trametinib, it showed better progression-free survival, almost 4.2 months, and in comparison with the single agent. And we have also data that the use of encorafenib cetuximab showed better response rather than the other combination. So based on that, of course, we have two trials. We have Beacon trial for the second line, will be discussed by Dr. Amjad, and we have the Anchor for the which is Anchor trial for the first line, and it is a single arm phase 2 study for encorafenib, binimetinib plus cetuximab in previously untreated BRAF V600E mutant metastatic colorectal cancer, which showed promise. And we can see that the median time to treatment, we reach it to up to 5 months almost. And we have confirmed now objective response rate around 50%. And we have very nice disease control rate, almost 85% by the use of Anchor protocol and by the use of cetuximab, this encorafenib, binimetinib, and cetuximab. So now we have option to use in the BRAF mutated patient, either to use the triplet plus anti-vascular endothelial growth factor, which we have good and strong data from the TRIBE trial, or we can use the doublet by the use of the Beacon approach. What about the maintenance? The maintenance is very interesting topic, and we know that a lot of debate about the maintenance therapy in this patient. And we have very nice data from British France trial, maintenance treatment with cetuximab versus observation in RAS wild metastatic colorectal cancer. This randomized phase 2 trial, British trial, showed that they compared the maintenance cetuximab versus observation only, and they ended up that we have almost gaining of 6 months progression-free survival. When we use the cetuximab maintenance, we have around 34% almost progression-free survival, and in comparison with the observation only, we have only 7% progression-free survival. So now we have clear answer. This is one example of the maintenance trials which showed very impressive role for the cetuximab maintenance instead of observation only. And we can see the separation of the curve that even after the progression-free survival too also maintained after follow-up of 30 months. Now, the NCCN guidelines, we can see clearly they updated their first-line recommendation that we can use For the patient with initial therapy, there is no difference between using FOLFOX bevacizumab if the patient is mutated, RAS mutated, versus FOLFIRI. Simply, we can use one of the combinations, while for the patient with RAS wild type, the use of cetuximab or panitumumab is the left side is strongly recommended. And now they updated, as we mentioned, for the use of nivolumab plus ipilimumab, or Bimbro, as Bimbro is preferred because of the data which we have for the microsatellite high cases. And if the patient unfit for intensive therapy, still we have options either to use 5-fluorouracil plus or minus BIF, Xeloda bevacizumab. We can use cetuximab or panitumumab for left-sided as single agent also if the patient is not fit. And also we have to consider even the use of trastuzumab plus pertuzumab or lapatinib in cases of HER2 positive, amplified, and RAS and BRAF wild type. So what take-home messages now we have? We are using using anti-EGFR and RAS, BRAF wild type, right side metastatic colorectal cancer. Now we have enough data, as we showed from Wang meta-analysis and pan-ISMO consensus, that we can use them in, when cytoreduction is high priority objective because of the excellent response rate, for downstaging based on the significant overall response rate. So we can use adopt this approach. Now, we have now evidence based on that maintenance with cetuximab monotherapy for those who have disease control, either stable disease or highly responsive disease after 8 to 12 cycles based on macro study and many other trials, as we showed, that demonstrating non-inferiority of cetuximab monotherapy versus cetuximab plus FOLFOX FOLFIRI. But these data, we have to be cautious that these data cannot be extrapolated to all anti-EGFR. We have data from Valentino trial which demonstrated the inferiority of panitumumab monotherapy versus panitumumab plus chemo in the maintenance setting. Now, when it comes to the chemo backbone flexibility, we can see that we can use FOLFOX with cetuximab. So, chemo backbone flexibility either to be cetuximab to be combined with FOLFOX or FOLFIRI or FOLFOXIRI, and it's not to be restricted only with FOLFIRI as we some people think. And this is based on Crystal, Taylor, FIRE3, SWAG, CLGB trials. And finally, we can see that for RAS wild BRAF mutated cancer, cetuximab plus encorafenib may be a recommended regimen as per Anchor trial, which you mentioned, or to be considered in the later lines as per Beacon trial. So there is place for the use of cetuximab plus encorafenib. And now we have enough good data from the Anchor and also from the Beacon and the advanced lines. And thank you very much. We'll leave the questions till the end. Now I will introduce my colleague, Dr. Amjad Rahman. Dr. Amjad Rahman is consultant medical oncology at Asir Central Hospital. He will continue the journey of treatment of metastatic colorectal cancer by tackling the second line of metastatic colorectal cancer. The mic is yours, Dr. Amjad.
Assalamu alaikum, and I welcome all. Dr. Ahmed for introducing. And we are today lucky to have Dr. Waleed with us. He is an expert in GI malignancies, and inshallah we will benefit from his experience and knowledge. And I am thankful to Dr. Ahmed for having the ground to set for me to carry on the journey of the management of metastatic colorectal cancer patients. So this is We will discuss the treatment beyond progression of RAS wild type metastatic colorectal cancer. This is a large topic, but I will try to be brief and to have overview of the topic. Next, as we know, next, as we know that metastatic colorectal cancer is a very common malignancy, but over the last 20 years we have seen great advances in the treatment and management of metastatic colorectal cancer. And there are multiple drugs that best way to combine and sequence these agents is still evolving. Next. With the development of these new drugs, the overall survival, which was about 6 to 10 months in the case of metastatic colorectal cancer, has now improved to 30 to 60 months with appropriate selection of the T drugs. Then next, there are multiple drugs available. Chemotherapy backbone that Dr. Ahmed has mentioned, they mainly consist of 5-fluoropyrimidine, that is 5-FU, or in combination with the leucovorin or the RODA. And there are the different combinations of this with irinotecan in the form of FOLFIRI or with bevacizumab. A triplet FOLFIRI is also available. We can also use the RODA or 5-FU and irinotecan alone, but auxiliary effective when used alone. There are multiple targeted agents which are approved in the first line and also in the later lines of treatment. Next. So there are many biological drugs available which are targeting endothelial growth factors and their receptors. There is anti-EGFR monoclonal antibodies which are approved for use in RAS and BRAF wild-type tumors. Regorafenib is an orally active anti-angiogenic small molecule tyrosine kinase inhibitor. There are BRAF inhibitors approved for use in V600E mutant BRAF mutant colorectal cancer, HER2 targeted therapies which are used in HER2 overexpressing tumors, and immunotherapy which are approved for MSI high or deficient mismatch repair tumors, and also there is some data for their use in high tumor mutational burden. The tropomyosin receptor kinase inhibitors, that is darotectinib and entrectinib, they are approved for use in TRK fusion positive cancers. Next. So, how to select appropriate treatment for patients with metastatic colorectal cancer? There are multiple parameters to take into consideration. For example, patient characteristics, what is the performance status, their comorbidities, and in the later lines of treatment, it is very important to see that what the patient has received in the adjuvant setting or in the previous lines of treatment. Similarly, tumor characteristics like tumor burden and tumor location, like right eye versus left sided, as explained by Dr. Ahmed, is very important. And molecular characteristics of the tumors are becoming much more important with the availability of new targeted therapies, and these include RAS, BRAF, MSI, and HER2 testing. And as we have seen that with first line, almost all the patients are eligible for treatment. But as we progress, the number of patients who are eligible for later lines of treatment become less. So most effective therapies should be offered to the patients in the first line. And we have seen that with the median survival increases with increased lines of chemotherapy. So we should offer the patients all the available treatments according to their situation. Next. Next. This table summarizes that even in the third line or beyond, many patients are still eligible for treatment. For example, in FITCH patients, the last line shows that about 50 to 60% of the FITCH patients may still be eligible for third line and beyond treatment for metastatic colorectal cancer. Next. And with these availability of these drugs, the median survival, which was about 6 months with the best supportive care, has now improved to about 3 years with the addition of all these targeted therapies. So there is significant improvement in survival of the metastatic colorectal cancer over the last 2 decades. And as we are having multiple drugs available, so there are certain recommendations which have to be followed for testing of the patients. For example, KRAS, NRAS, and BRAS mutation status should be tested in all metastatic colorectal cancer patients at the time of diagnosis, while MSI and MIC status or MMR, which is the same, they should be tested for all newly diagnosed colon cancer patients. This because these tests might be helpful in the earlier stages of treatment also, not only in the metastatic disease. Similarly, HER2 testing should also be done to find out the patients who have overexpressed HER2 the gene, so that these can be benefited for HER2 targeting therapy. NTRK fusion, these are very rare in colorectal cancer. From 0.2 to 2% of the patients are NTRK fusion gene positive. But these patients should be detected, because if these targets are found, the patient should be offered treatment with the NTRK fusion antagonist inhibitors like larotrectinib and trectinib, because these drugs are having high response rates in these subset of patients, and the responses are quite durable. And so that if you find NTRK fusion, they should be treated earlier in the lines of treatment. Next. As we have seen that about 45% of the KRAS tumors are mutated, while 48% to 58%, 50% are wild type, about 5 to 10% are NRAS mutate. Next. Okay. So similarly, the extended this diagram shows that the extended RAS analysis in the study population showed that in addition to exon 2 KRAS mutation, there are additional mutations in the RAS group, that is about 23% in the exon 3, 4, and 2, 3, 4 of NRAS gene are also mutated. About 6% of the population has a V600E mutation in the BRAF gene. Next. So, second line chemotherapy, multiple factors have to be taken into consideration when we speak about second line chemotherapy. That what is the performance status, what the treatment previously patient has received, to select the appropriate treatment in the second line setting. For example, in this EPIC study, which is a phase 3 trial, the patients who have received auxiliary platinum-based chemotherapy in the first line, they were randomized to cetuximab plus irinotecan compared to irinotecan alone. And in another trial, which is the CAPRI, this is a phase 2 trial in which the patients who received FOLFIRI plus cetuximab in the first line, they were randomized to receive FOLFOX plus cetuximab compared to FOLFOX alone. And in the results of these trials showed that next, and the EPIC trial showed that there was significant improvement in median progression-free and survival and objective response rates, but there was no improvement in overall survival. But this EPIC trial supports the use of cetuximab irinotecan in first line after first line treatment of in second line treatment of patients when they have progressed on chemotherapy. Okay, in this trial, the patients who subsequently received the irinotecan and patients who subsequently received cetuximab also led to improved overall survival. So the patients who have received only chemotherapy in the first line, then progress, they are good candidates to receive cetuximab plus irinotecan in the second line. Similarly, next. Similarly, in the second line, the patients who received second cetuximab plus FOLFOX in the second line after progression on irinotecan and cetuximab, the patients who were RAS and BRAF and PI3K kinase mutation wild type, they have significant improvement in progression-free survival, and this also supports the use of continued use of cetuximab in the second line while the chemotherapy backbone is changed. Because these patients initially received irinotecan, they can continue cetuximab with FOLFOX in the second line. If the patient has initially received bevacizumab and cetuximab in the first line, then the two studies, one is the PRODIGE 18, which is a phase 2 trial. They evaluated that the patients upon progression on bevacizumab containing chemotherapy regimens, they randomized to cetuximab plus FOLFOX when it was compared to bevacizumab plus FOLFOX. Next. And And in this trial, the addition of cetuximab to chemotherapy when it was compared to bevacizumab plus chemotherapy, there was no statistically significant difference in progression-free survival or overall survival. Numerically, the bevacizumab arm favored but that did better. So, in this population of patients who progressed on bevacizumab containing chemotherapy, the patients might be candidate for bevacizumab continuation with change of the chemotherapy blackboard. Next, so is so in the COMET trial, which was a phase 3 trial in which the patients who had progressed on bevacizumab chemotherapy, rituximab was tested in second and third line, and again it did not show any benefit, the improvement in significant improvement in progression-free or overall survival by the addition of rituximab in the second or third line. So it is important that the first line treatment matters. So the patients who are appropriate candidates for example, left-sided tumor with the RAS and BRAF wild-type tumor, they should be initially treated with EGFR-based chemotherapy so that they can get the maximum benefit of different lines of chemotherapy. But if the patient progressed on bevacizumab containing chemotherapy, continuation of bevacizumab is one of the appropriate options. Next. Next. Okay, and there is good biological rationale for using of EGFR therapy prior to anti-VEGF therapy because in EGFR-based therapy they directly inhibit the growth of tumor cells, while anti-VEGF therapy they affect indirectly by inhibiting the blood supply of the tumor. So it is important to downstage and cytoreduce the tumor by using the EGFR in the first line rather than anti-VEGF in the appropriate setting. Next. The other anti-EGFR monoclonal antibody, panitumumab, has also been evaluated for the management of patients who have progressed on first-line fluoropyrimidine-based chemotherapy, and these patients have not received irinotecan or any anti-EGFR therapy in the first line. And they were randomized 1:1 into panitumumab plus FOLFIRI compared to FOLFIRI alone, and primary endpoint was overall survival and progression-free survival. And this study showed next. And this study showed that there was significant improvement in the progression-free survival and objective response rate in KRAS wild-type exon 2 wild-type tumor, while overall survival was not significantly improved by the addition of panitumumab to chemotherapy. Similarly, in patients who were exon, when it was compared, exon 2 mutations were compared to RAS wild type, all RAS wild type, again, progression-free survival was significantly improved, while there was no significant improvement in overall survival. So, based on this study, it is the panitumumab is also an option upon progression. Next. So we have seen that in the second line setting, the patients who have received initially the chemotherapy only, addition of cetuximab to the chemotherapy backbone improves in the second line, has improved outcomes in the second line, while the patients who have received bevacizumab and then progress, continuation of bevacizumab is one option. On the other side, they can also, if there is some of the patients might benefit of shifting to anti-EGFR cetuximab-based chemotherapy, particularly those patients who have rapid progression on bevacizumab chemotherapy. In such patients, we may shift the treatment to anti-EGFR, for example, cetuximab, to get a rapid tumor regression in size. So, can we go to the back, one slide back? Okay, yeah. There is good biological rationale for cetuximab relapse challenge strategies. Because first, when the tumors are diagnosed, they have more cetuximab sensitive clones. And when they get treatment with anti-anti-GFR treatment, there is and then the cetuximab resistant clones increase and the tumors become irresponsive to the treatment. And upon disease progression, when there are more cetuximab resistant clones, we can shift the treatment to other second line chemotherapy. And in such cases, later on cetuximab sensitive clones increase again. And in this case, when there are more cetuximab sensitive clones, we can re-challenge with third line cetuximab based chemotherapy. Next, and so next, so the RAS status is not fixed and it is dynamic over time. Initially, there are more mutant and more wild type RAS tumor clones. When treated, there are more RAS mutant clones, and again they become sensitive to when their therapy with anti-EGFR is stopped. There is more wild type RAS wild type tumors become more prevalent. So, liquid biopsy is a useful tool for monitoring dynamic RAS status. Circulating tumor DNA has been demonstrated to be useful in many situations because it has been reported, demonstrated by different studies that circulating tumor DNA mutations they replicate those mutations which are found in tissue biopsies. And this circulating tumor next And this circulating tumor DNA can be used at the time of diagnosis when we can see that which RAS mutations are not. They can also be used to monitor minimal residual disease, tumor response, and acquired resistance at the time of progression of the disease. If we use circulating tumor DNA, they can detect the resistant clones. And next, okay. And circulating tumor DNA also can be used as a rapid surrogate of tumor response because the half-life of circulating tumor DNA is only in minutes to hours. And in responding patients, the circulating DNA level declines to more than 90% in 2 weeks. So it is a good marker for evaluating response. But still, there are more studies are needed to find out the effectiveness of circulating tumor DNA because many studies have shown discordance between circulating circulating tumor DNA and with the tumor tissue itself. Next, next. Okay. In this small study from South Australia, where the patients who were having metastatic colorectal cancer and they had received EGFR re-challenge, and in next, and this and in this study of 22 patients, by the re-challenge cetuximab, they achieved a disease control rate of more than 45%, and median overall survival was 7.7%. And this retrospective analysis showed that EGFR region provides a clinical benefit in patients with RAS wild-type metastatic colorectal cancer patients. Next, and this another next, and in this phase 2 multi-center single-arm study, in which the patients who had initially treated with chemotherapy, they received on progression cetuximab, and then with cetuximab-based treatment, they achieved stable disease for 6 months or more, or they had partial or complete response. And at the time of progression, cetuximab was stopped, and they were treated with an alternate chemotherapy. And in the third progression, they were treated with cetuximab re-challenge. And at the third after third progression with cetuximab re-challenge, they achieved an overall response rate of 54% approximately. And in this setting, their median progression-free survival was 6.6 months. So this study showed the efficacy of cetuximab re-challenge in the patient who have progressed on previous cetuximab-based chemotherapy and followed by cetuximab-free interval. Next. And this in this cricket trial, which is also a phase 2 multi-center single-arm study, patients were treated with the first line with cetuximab plus chemotherapy, and when they progressed, the second line they were treated with bevacizumab plus chemotherapy, and upon progression, they were again treated with third line cetuximab. And at the second progression, the patient were also analyzed by cell-free DNA analysis. The RAS status was evaluated, and its study has shown that there was statistically significant progression-free survival and overall survival advantage in those patients who were metastatic, who were RAS wild type based on circulating tumor DNA. Next. So, and also the RAS mutant clones, half-life of them is approximately 4.4 months. So, if after first line of anti-EGF therapy, if the secondary challenge is after about more than 5 to 6 months, we can get better response. In general, the more time since the last anti-EGFR therapy, the more benefit is with re-challenge. Next. And in the continuum of care, the evaluation of EGFR status using the circulating tumor DNA might be evaluable. It can tell us about the development of resistant clones, and it can also help us to guide the further treatment. Next, and FIRE4 study. Next. And FIRE4 trial, which is underway, it is randomizing the patients into cetuximab first line compared to bevacizumab, and upon progression they will receive bevacizumab plus any FOLFOX chemotherapy, and when on the third progression they will be randomized again to cetuximab plus chemotherapy of physician size. And at baseline and at each progression, the tumors will be analyzed by liquid biopsy by circulating free cell DNA, and this study may has the potential to inform us about the value of cetuximab, may establish the value of cetuximab re-challenge and the use of liquid biopsy, and the results of this study are expected by 2025. Next. And the overall survival is the primary endpoint of FIRE4 study with multiple other secondary endpoints. Next. So, in summary, cetuximab has a role based on the phase 3 trial data in the first line setting. Also, additional evidence suggests that cetuximab is effective treatment in second and third line, and there is emerging evidence that re-evaluation of RAS status in the liquid biopsy these will help in achieving a more personalized approach to the treatment of colorectal cancer patients. Next. In addition to monoclonal antibodies in the second line and beyond, there are other approved medications which can be used in these patients who have progressed on first line treatment, and these include bevacizumab. Next. These include bevacizumab, which has been studied in the Ml18147 study. In this study, patients who have progressed on first-line treatment of containing bevacizumab and chemotherapy, they were randomized 1-to-1 to continue bevacizumab with alternate chemotherapy or the alternate chemotherapy. For example, if the patient in the first line received FOLFIRI, they were shifted to FOLFOX and vice versa. And overall survival was the primary endpoint, and this study of continuation of bevacizumab achieved this primary endpoint of overall survival, which was statistically significantly increased by continuation of bevacizumab in combination with chemotherapy. Next. And also progression-free. Next. And progression-free survival was also statistically significantly improved. Next. And when the overall survival was evaluated by KRAS wild type status, there was statistically significant improvement in survival in those patients who had KRAS wild type tumor. While in KRAS mutant tumor, the overall survival was not improved. Next, while progression-free survival was most improved in KRAS wild type and KRAS mutant tumors with the continuation of bevacizumab plus chemotherapy compared to chemotherapy alone. Next. Next. So in conclusion, this Ml18147 phase 3 study showed that the continuous bevacizumab plus alternate chemotherapy is effective in second-line approach because it has led to increase in overall survival and progression-free survival, and in the KRAS, it is more effective in KRAS wild type tumors as compared to KRAS mutant tumors, and this can be considered as a treatment option for those patients who have already progressed on bevacizumab containing chemotherapy. Next. Next. And another study in E3200 evaluated the role of bevacizumab plus FOLFOX in those patients who have previously treated with irinotecan-based chemotherapy. And they were randomized to bevacizumab plus FOLFOX compared to FOLFOX alone. These patients have not received any bevacizumab in the first line. They were only treated with irinotecan-based chemotherapy. Primary endpoint was overall survival. Next. Next. And this study also met its primary endpoint of significant increase in overall survival and progress. Next. And progression-free survival and next. And response rate. So the addition of bevacizumab to chemotherapy FOLFOX in irinotecan after irinotecan failure led to significant improvement in overall survival, progression-free survival, and objective response rate. So we can use bevacizumab in those patients who have progressed on chemotherapy in the second line. Next. Next. So if we compare cetuximab to bevacizumab in the second line, after failure of first line bevacizumab-based chemotherapy, continuation of bevacizumab in second line while switching the chemotherapy banbos is one option because it has led to significant improvement in overall survival, while the other also the cetuximab can also be used in this setting because based on the EPIC trial data. Next. The other drugs which are approved for use in second line, they contain aflibercept. Aflibercept is a recombinant fusion protein consisting of the extracellular domains of VEGF receptors 1 and 2. And it acts as a decoy receptor for VEGF1, VEGF-A and B, and it binds and these receptors, vascular endothelial growth factor A and B, bind to this decoy receptor protein, and in this way it prevents the binding of the VEGF to actual receptors on the cell surface, and this way they inhibit the downstream signaling pathway. And next. And this has been studied in a Valour trial in which patients who had progressed on exalipitation-based chemotherapy, they were randomized to aflibercept plus FOLFIRI compared to FOLFIRI overall survival as primary endpoint, and this study met its primary endpoint of overall survival. And then this study met its primary endpoint of overall survival, and also which was statistically improved, and also progression-free survival was statistically improved by the addition of aflibercept to FOLFIRI. So this based on this study, the combination of aflibercept and FOLFIRI is approved as second-line treatment. Next. And the aflibercept is both have EU and US approval as second-line after progression on previous oxaliplatin-based oxaliplatin-containing regimens. Next. Ramucirumab, this is a monoclonal antibody. Next, this is a monoclonal antibody which is bind to extracellular domains of vascular endothelial growth factor receptor 2. Next, and it has been studied in patients who have progressed on bevacizumab and oxaliplatin-based chemotherapy, and they were randomized into ramucirumab plus FOLFIRI compared to placebo plus FOLFIRI with overall survival as primary endpoint. And in this population, next, and it met such primary endpoints of increased overall survival. And next, and progression-free survival was also significantly improved in the RAISE study by the addition of ramucirumab to FOLFIRI. And based on this trial, next, and based on this trial, ramucirumab plus FOLFIRI has been approved for second-line treatment in those patients who have already progressed on bevacizumab oxaliplatin combinations. But both this aflibercept and ramucirumab are not commonly used because of their increased toxicity and price, and also there are other options in the same situation where bevacizumab has also shown efficacy in after progression on oxaliplatin-based chemotherapy, or in those conditions where bevacizumab was used in the first line. So mostly the people are using bevacizumab as compared to aflibercept or ramucirumab. Now we come to a small molecule tyrosine kinase inhibitor, regorafenib. Next. And regorafenib, it is a small molecule which has been involved into inhibit multiple protein kinases which are involved in oncogenesis, tumor angiogenesis, and regulation of tumor microenvironment. Next. And this regorafenib has been evaluated in CORRECT study, where regorafenib plus best supportive care was compared to placebo plus best supportive care, and these patients have already treated and they were randomized to regorafenib versus best supportive care versus placebo plus best supportive care. Primary endpoint was median overall survival. Next. And in this study, the regorafenib met the primary endpoint of improvement in significant improvement in overall survival, while progression-free survival was also statistically significantly improved. Objective response rate was not improved, was higher, but was not statistically significant. Anyhow, the side effects were common grade 3 and 4 side effects which were common by the regorafenib was fatigue, hand foot syndrome, diarrhea, and hypertension. These were well managed, manageable side effects. The toxicity profile was not all that toxic. So next. So based on this data, which the regorafenib next. So based on this correct data, the regorafenib led to significant improvement in overall survival and progression-free survival, and has been approved by FDA in the third and more lines of treatment of metastatic colorectal cancer. Next. TAS-102 is an oral anti-tumor nucleoside. It contains two components, trifluridine and tipiracil. Trifluridine incorporates into DNA and leads to DNA strand breaks, and in this way inhibits the cell proliferation. while tipracil is an inhibitor, while tipracil while tipracil has potentiates the effect of trifluridine. It has been evaluated in this study, which is a recourse study, in which the patients who were previously treated with 2 or more lines of chemotherapy for metastatic colorectal cancer, they were randomized to test 102 plus best supportive care compared to placebo plus best supportive care with overall survival as the primary endpoint. Next.
Dr. Amjad, because of our running out of time, if you can conclude in the upcoming 5 minutes, if you can
Okay.
conclude. Okay.
Okay. Next. Next. Okay, this study met its progressively survival improvement, and when we compare these 3 studies of cricket, go next. Okay, next, yes. When we so Tipracil is improved. This TAS 102 is based on the recourse 102 improvement in overall survival. It is approved for treatment in the third line and beyond. When we compare cross trial comparison are not good, but when we compare these trials in it has shown that the re-challenge trial of Stuximab, that is the cricket trial, it led to improvement in overall survival, progression-free survival, and an objective response rate compared to the Regorafenib and TAS 102. Next, next. And safety profile also favored the cetuximab re-challenge. And so cetuximab re-challenge is according to certain ESMO guidelines also. Next. Okay. So re-challenge with the cetuximab monoclonal antibody, there is very data to use this regimen in the patients who have progressed already on this. So next. So BRAF mutated colorectal cancer has poor prognosis, and it has been a triplet of encorafenib, cetuximab plus minus binitumab has been evaluated in BRAF V600 mutant colorectal cancer 3-arm study, and in which a triplet by binimetinib and corafenib and cetuximab was compared to doublet of encorafenib cetuximab to control arm of FOLFIRI plus cetuximab. And the primary endpoint was overall survival and objective response rate. Next. And this study also met when the triplet was compared to control arm, statistically significant improvement in overall survival, and also doublet led to statistically significant improvement in overall survival. Response rate was also improved as compared to the control arm. Next. Okay, progression-free survival was also statistically improved in both in the triplet and doublet arms. Next. Okay, so based next. So based updated analysis of Beacon trial was presented in ASCO last year, and it showed that the patient at a median follow-up of 12 or 8 months, only 3% of patients were on treatment in the control arm compared to 13 to 14 in the triplet and doublet, and median overall survival of 9.3 months was achieved in the doublet and treatment triplet arms compared to only about 6 months in the control arm. So, based on this data, the doublet is approved and sufficient and is now considered standard of care in the second line or beyond treatment of BRAF metastatic colorectal cancer and is FDA approved. Next. And now in the era of immuno-oncology, many immune checkpoint inhibitors are also being used in metastatic colorectal cancer, and in this case study which has presented last year in ESMO. Next. In this case study, in the patients who were RAS wild type treated with the anti-EGFR treatment, upon progression they were treated with cetuximab and adalimumab, which is a PD-L1 inhibitor, and the primary endpoint was overall survival. Next. And it led to more than 13 months of overall survival. Next. Progression-free survival was next. Yes, and also progression-free survival was 3.6 months. Next, next. And based on this study has shown that cetuximab plus avelumab as a real challenge study is effective and well tolerated. But next, and this chemo-free regimen has a role in metastatic colorectal cancer, and also in patients who are deficient in mismatch repair gene. Also, they can be used treated with PD-L1 inhibitor pembrolizumab. Next, and next, and this pembro has shown significant in mismatch deficient tumor. There was significant improvement in median progression-free survival, and next, and overall survival. Next. And in checkmate 142, nivolumab monotherapy and in combination also led to significant improvement in their primary endpoint of objective response rate and are approved in this setting. Next, next, okay. So the next, and overall survival was also improved by the in this checkmate 142 trial at median follow-up of 42 months. 1 month still the median overall survival not reached. Next, next. So in summary, in PDN1 blockade is active in DDA has a durable response, and if the patients are having this MSI high or D deficient mismatch repair, it is better to use these treatments in the earlier in lines because if they respond, they have a more durable responses. Next, next, next. And the patient who are having overexpressed HER2, which is usually found into 3 to 5% of the metastatic colorectal cancer patients, various combinations of anti-HER2 drugs has achieved increased improvements in objective response rate, median progression-free survival, and overall survival. And the drugs used are a combination of trastuzumab, lapatinib, trastuzumab, pertuzumab, are a or even recently trastuzumab tocatinib has been evaluated in these patients. The antibody drug combination of TDDX2 has also been shown improvement in survival and also objective response rate improved with the in patients who are HER2 positive, and TDM1 plus pertuzumab and also shown. So it's patients who have received all other lines of treatment and there are no good options available and they are HER2 overexpressing, anti-HER2 treatment strategies may be used in these patients. Next. HER2 is a new target now in metastatic colorectal cancer. It belongs to EGFR family of receptors and it emerizes other family members like HER2 and in this way affects the downstream signaling and this target has been next. And patritumumab deruxtecan is under trial in patients who are having HER3 as HER3 being the target. So over the last 20 years, we have seen multiple drugs and now improved for the treatment of metastatic colorectal cancer along different lines of management. Next. And with this, next. And also we have multiple options in the first line and later lines of treatment, and we have to individualize patients based on the treatments what they received previously, what is that biomarkers available, for example, RAS, BRAF, MSI high, and accordingly we can personalize treatment for each patient and get the best results for them. And next. And this slide already shown by Dr. Ahmed, and it shows that we different lines of treatment with different approaches, that initial intense chemotherapy, then maintenance, then re-challenge, and second line, third line, we can achieve the best response, and which and with this approach, the median survival is approaching up to 3 years in metastatic colorectal cancer, and which is a good achievement. And thank you very much.
Thank you, Dr. Amjad, for this comprehensive talk. And now we'll move to the third and final part to our colleague, Dr. Waleed Alselwi. Dr. Waleed is a consultant medical oncology at King Fahd Specialist Hospital in Dammam, and he specializes in the GI and also GU tumors, I think. And he is going to share with us challenging case in metastatic colorectal cancer. The mic is yours, Dr. Waleed.
Thank you, Prof. Ahmed. Thank you, Dr. Amjad Rahman, for excellent talks. And you are covering really the first line, the second line, third line in very good way, and is very highly caliber of the educations. Thank you as usual. And I have to, it is my pleasure to become with you today, and Ramadan Kareem for all. And also I have to thank Merck to arrange this activity. I will try to become fast in my cases, because I think already our dear friends is really give us a lot of the informations. We'll start as Dr. Prof. Has mentioned. I have the first case is a 50 years old male patient diagnosed with colon cancer metastasis to the liver, that is in December 2015, as metastatic colorectal cancer liver metastases, that is December 2015, KRAS wild type, MSI test initially were not done, and then later on become low. There is positive family history of metastatic colon cancer, first degree relative of colon cancer. As Dr. Amjad Rahman and also Prof. Ahmed, he mentioned, this is very nice slides, mention what influence of the metastatic colon cancer based on patient characteristics and molecular characteristics, tumor characteristics, and that is the importance of the looking of our patients. And Dr. Ahmed has mentioned that how those is patients with continuation of the chemotherapy that led to the improving progression-free survival and overall survival. This also the cartoon is shown by Dr. Rahman. This is shows of the KRAS patient 45% and wild type 48%. For that's when we are looking for metastatic colon cancer, we have to look from the beginning for a KRAS status, BRAF status, and the MSI and HER2. This is just the cartoon showing of our EGFR and vascular endothelial growth factor for our fellows and assistant, where is those targeted and where we are looking for to targeted by the anti-EGFR or anti-vascular endothelial growth factor, or also by anti-HER2 or BRAF status. This is the showing of the different type of colon cancer. We have four types that is mentioned by Dr. Prof. Ahmed. I'm just very quickly remind those is the percentage and the distribution of those patients according to the histopathological classifications. And this is how is the journey of colon cancer is growing by the genetic change in colorectal cancer. And metastatic colorectal cancer is a heterogeneous disease, is not one disease as Dr. Prof. Ahmed has mentioned, and we are looking for those patients carefully to give him the best available drugs regarding if there is any is left side, right side, BRAF mutant, RAS, BRAF wild type. And when we are to start with our patient or any patient with colorectal cancer, we have to check for what is a routine performed in our metastatic colorectal cancer patients. Usually, if we are doing to home extended RAS mutation testing, BRAF mutations, or DMR, MSI high, or HER2, or all of the above. The answer is the all of the above. Is the availability now? We should do all of the above for our patient to tailoring the best available medications. My patient is the CT scan shows liver metastasis. This patient is unresectable from the beginning, and then we discuss in our tumor board, and then we discuss to the patient what is expectations, what is any rule of the extent overall survival. We have to tumor shrink, and then disease control, and it might be he need surgeries, a male patients. Then we discuss in the tumor board. Our tumor board discussion is not for surgery upfront. We decide to give the conventional chemotherapy started in December 2015. Folfoxitoximab being wild type KRAS 6 cycle has good response. Then surgery, left hemicolectomy in March 2016, and histopathology showed moderately differentiated adenocarcinoma, T3N1 positive lymph nodes from 25 lymph nodes, and then metastatectomy of the liver lesions came as also with metastatic carcinoma from the colonic origin. As Prof. Ahmed has mentioned, this is the very nicely discussion about crystal study and RAS wild section, and those is how it's improving in the wild type patients. KRAS, I will not go in details, just in reminding why choose the cetuximab with Folfox or Folfiri, and shows there is progression-free survival and overall survival. Then the FIRE3, Folfiri, bevacizumab or cetuximab in the left side with overall survival by the tumor location clearly shows in those patients with left side colon cancer, the cetuximab is preferred to start with. And then this shows how impact of the cetuximab on anti-EGFR therapy in the rapid debulking and then lower potential of the resistance clone, and antivascular can be effective as the second or subsequent line, as Dr. Rahman has mentioned. Then this is the phase 3, shows clearly of those patients improve for progression-free survival and also overall survival in the second line setting. What we do then is for our patient, chemotherapy cetuximab after surgery or chemotherapy surveillance or maintenance cetuximab. Pseudo-adjuvant chemotherapy was given, Folfoxitoximab 12 cycle last in August 2016. Then surveillance, CT scan on May 28 show slowly growing pulmonary nodules in both lungs, worsen for metastasis, and then tumor markers is starting to raise, and that is before it's normal. And then this CT scan confirmed there is disease progression. We discuss in the tumor board with a thoracic team, and then decide for surgery, referred for thoracic surgery, underwent mini thoracotomy, and metastatic was done and came as metastatic adenocarcinoma of the colonic origin. And also the board came as metastatic nodules from the metastatic adenocarcinoma, and patients giving the chemotherapy after that 6 months of chemotherapy, and CT scan after that by 8 months shows disease progression over chemotherapy. That time he refused, and our patient is lost follow up for a while. And this is looking for cetuximab Folfox first line. What is the impact on subsequent therapy, as Dr. Rahman has mentioned? Then cetuximab Folfox Folfiri and second line, and then we can consider for the third line cetuximab as the re-challenge. On the second line, we can consider the Avastin of bevacizumab. Again, he presented after that with fatigue, weight loss, about 15 kg, abdominal pain, July 2019, admitted for symptoms control and restaging. CT scan shows clearly disease progression locally and liver, lung metastasis unresectable at this time. CT scan July disease progression, interval progression of the right side, peritoneal deposits also showing that significant disease progression. And this is the CT scan of my patients. Tumor markers was also increased to 980, ECOG promestasis 1. What is the next time to discuss regorafenib, TAS1 and 2, rate challenge, immunotherapy, or further testing? His MSI this time is low, HER2 was negative. Because patient is doing well, we re-challenge with Folfox high burden of disease with Avastin protocol, good response, and radiological and biochemical tumors marker decrease. Then maintenance on Zeroda Avastin according to the Cairo 3, the maintenance study for progression-free survival benefit, and then also recent CT scan, CT scan in October 2019 showed no local recurrence, but there is overall good response, interval reduction of the intra-abdominal wall, which is maintained on the maintenance therapy. and then CT scan showed partial response with clinical improvement, no more symptoms. Echo is 0, tumor markers was normal. Then March 2020, again show the CT scan how it's progressed, and started TAS 1 and 2, doing well, treated the medication till October 2019. And this is clearly shows by Dr. Rahman how is the TAS 1 and 2 improve the progression-free survival in metastatic colorectal cancer in the third line, and then progression-free survival. November 2020, again, disease progression. We started Recombinant, and according to the correct study, and shows that patient is responding for a while and then become progress again. CT scan shows liver metastasis, protein metastasis. CA again was raised to 1,345, still equal prognosis is 1. And this time we restarted again, re-challenge with FOLFIRI cetuximab, being a good response to start with cetuximab, and clinically become much improvement of the abdominal pain, anorexia, and fatigue. Interim assessment of the CT scan showed partial response. CA dropped from 1,300 to 257, and continued on FOLFIRI cetuximab another 3 months and become asymptomatic. Echo prognosis is 1. CT scan January 2021 has interval regression of the peritoneal metastases and significant interval regression in the size and number of hepatic and pulmonary metastases. We switch from the FOLFIRI to the irinotecan cetuximab protocol till now, and is doing well till now. Alhamdulillah. This is the cetuximab re-challenge protocol as mentioned. When the patient with cetuximab sensitive tumors, then first line cetuximab chemotherapy, cetuximab insensitive tumors, and then non-cetuximab containing treatment, anti-EGFR treatment, holidays, what is mentioned, and then RAS mutant cetuximab sensitive tumors. As we mentioned there is a liquid biopsy can be helping us very important in this stage of the disease to think if the patient is still as sensitive and EGFR is still wild type. As this is the Kirkut study showing that FOLFIRI cetuximab progression disease, then bevacizumab with chemotherapy, then progression disease, and again re-challenge with irinotecan cetuximab, showing those overall response rate 21%, with median progression-free survival 3.4 months, with median overall survival was 9.8 months. This is for case 1. We have a case 2. This another 55 years old male patient, diabetic hypertension, presented with history of weight loss 12 kg within the last 6 months, associated with bleeding per rectum and change of bowel habit, sought medical advice and referred to us. Colonoscopy showed sigmoid mass, biopsy, moderate differentiated adenocarcinoma, CA 760, CT cap was multiple liver metastasis and peritoneal metastasis, is unresectable, KRAS wild type, BRAF wild type, discussed in MDT tumor boards, being multiple liver metastasis, N number of metastasis, and peritoneal metastasis, unresectable. This is the CT scan. We discussed with the patient the first line treatment, as Dr. Ahmed has mentioned, the best treatment to start with a chemotherapy first line, and that is going to the diagnose, biomarker testing, and then treatment goals and first line therapy options. Then how is treatment sequences? We have to put in our mind the sequences and on treatment management. Started FOLFOX cetuximab protocol 6 cycle. Interim assessment showed good response of local disease and liver metastasis with partial response of peritoneal metastases, and then hepatobiliary surgical team assessment, unresectable bilobular metastasis with vascular involvements. Continued FOLFOX cetuximab for another 3 months, and then what is next after he is finished of the 6 months of the chemotherapy with cetuximab, if any holiday chemotherapy, maintenance strategy, or just follow-up. As this mark study, cetuximab maintenance therapy after induction chemotherapy, cetuximab with chemotherapy, and then maintenance chemotherapy, or cetuximab FOLFOX, then treatment till disease progression. clearly shows there is in the KRAS wild type status, there is also significant progression-free survival. And also, as this is mentioned by the maintenance treatment with cetuximab versus observation in the RAS wild type, this prodigious study in the time of the uni cancer study also showing that it's clearly there is a significant progression-free survival benefit, and this is the study design between the cetuximab maintenance and observation study, and 6-month progression-free survival rate with cetuximab maintenance therapy with 35% in those patients with confidential interval 25 in the observation is 6.9%. Secondary endpoint progression-free survival after randomization with cetuximab is 41 compared with 5 in the median progression-free survival. With observation study also is 13 and compared with 2 months with the median progression-free survival. Again, as we know, the grade of the safety analysis of the first diarrhea, rash, hypomagnesemia, and fatigue is not that is high concern. It is a high safety profile of cetuximab. 6-month progression-free survival, cetuximab 35 compared with observation 6.9%. With median progression-free survival with cetuximab are with 5.3 months. Maintenance cetuximab was started, and maintenance cetuximab patient is maintained on for 19 months. And patient start to complain from the abdominal pain, anorexia, ECOG performance 1, CA was 230, CT showed disease progression in the peritoneum and new lying lesions. Second line chemotherapy FOLFIRI Avastin was started for 6 cycles, then showed CT scan partial response, CA dropped from 200 to 45. We continued on FOLFIRI Avastin for another 3 months with good tolerance, with mild diarrhea. Interim assessment CT scan shows good response of local disease and liver metastasis and partial response of peritoneal metastasis. Maintenance zero Avastin for 11 months started to complain from abdominal pain, CA 110 and ECOG still 1. Then CT scan showed progression of the multiple lung lesions and liver lesions. Unresectable MSI was requested, MSI is low, HER2 new was negative. This is the CT scan. What is next? Reaching with sulfoxytoxin protocol, or we start again because he has very good response to start with, and this time we ask for liquid biopsy, and interim assessment of CT scan showed good response, but actually we cannot do the liquid biopsy that time. And then CT scan showed good response of the lung metastasis, liver metastasis with peritoneal metastasis. Patient continued on sulfoxytoximab for 3 months. Then CT scan in August showed partial response to lung lesion and stable peritoneal lesions. Currently on maintenance cetuximab, doing well asymptomatic. ECOG 1 for reassessment after 6 cycles. We'll go very fast for the second, the case number 3. This is a 38 years old female patient, not known to have any chronic disease, presented with history of bleeding per rectum associated with significant weight loss, is 16 kg within the last 6 months. She had history of 1 year signs of system of in and of self-obstructions. Tumor marker CA is 2,461. CA 19.9 was 146. Colonoscopy shows ascending chronic mass. Biopsy borodeficient adenocarcinoma. NRAS, KRAS wild type. BRAF no mutation. MSI was low and HER2 was negative. This is the mass in the sigmoid in the ascending colon. This is the mass in the CT scan. This is the PET CT scan, shows the multiple liver metastases, and this is the cecal mass. We discussed in the multidisciplinary tumor board, in our tumor board discussion, being this patient upfront is not resectable with multiple liver metastases. We decide to go for a chemotherapy, being even the right side, but because we are looking for shrinkage of the tumors and the resectability, and she's young patients, we give the cetuximab Folfox 6 cycle, and then reassessment has excellent response. Underwent surgery for metastasis of the liver lesions and the resection of primary colon cancer, right hemicolectomy. Histopathology came as adenocarcinoma of primary colon, that is of metastatic lesions, and chronic lesion is T3 into disease. And patient is recovered well from the surgery, and we continued with pseudo-adjuvant chemotherapy. What do the guidelines say? ISMO consensus for clinically fit patient, patient clinically educated, or fit or not fit. If patient unfit patient, meaning is eco-prognosis 3 to 4 palliative care, and patient clinically fit, treatment goals is there is disease control, or we are looking for tumor shrinkage and for conversational to the resectability. Then we have to look for prevention or preventive relief of the symptoms, and we have to think about quality of life control and prolongation of progression-free survival and overall survival. That is the very important, the map and for us from the beginning. And then unlikely the proposed ISMO of the NCCN does not distinguish between the tumor shrinkage and disease control. NCCN no classification of the patient according to the goals and tumor shrinkage or disease control. Patient appropriate for intensive therapy. Some patients we can go for very highly intensive. That is mentioned by our dear friends about the triplet chemotherapy in some selected patients. If we are looking for a shrink of the tumor and resectability, FOLFOX or FOLFIRI, then cetuximab or panitumab, or FOLFIRI, 5-FU, capecitabine, FOLFIRI, FOLFOX, KBOX plus minus bevacizumab, or also sometimes we go for triplet FOLFOXIRI. Again, why is the tumor shrinkage important? That symptoms control, increase resectability, patient reassurance, prolong the survival, and improve quality of life benefits. Again, how does mode of the action translate to the ability to the shrink of the tumors? As that is mentioned of cetuximab FOLFIRI, 66% compared with FOLFIRI alone, 39%, and also in the prime, also 60% compared with 49%, and also when we go to the ONOI1, that's 38 and 38 by the bevacizumab FOLFOX and FOLFOX or Xerox alone, compared with the bevacizumab FOLFOX alone, showing with the combination of the anti-EGFR in the shrinkage of the tumors is much than the bevacizumab arm. Again, this is the FIRE3 in patient with 20 months compared to 21 months in patient with bev FOLFIRI, cetuximab FOLFIRI with very significant p-value, and the median progression is 38 months. And in the prime, also again, the 32% median progression-free survival with pan, FOLFOX, or FOLFOX alone. Depth of the response, as this in the FIRE3 also, that progression-free survival in cetuximab FOLFIRI, 48 compared to 32 with bevacizumab, and significant with deep response with cetuximab FOLFIRI. Right side again, it is as everybody has mentioned, this is the poor prognostic factor in the patient receiving chemotherapy alone in the clinical trials, and all we know that right side colon cancer is worse prognosis. Again, what is influence treatment choice in the metastatic colon cancer? That is the patient characteristic, including the age, comorbidity, performance status, prior adjuvant treatment, and tumor characteristic for resectability, tumor burden, tumor locations, again, patient preference, quality of life, toxicity profile, and molecular characteristics, RAS, BRAF, MSI high, HER2, tumor mutation burden, and NTRK gene. Colon cancer. Is a colon cancer is one disease? No, it's not a one disease. It's a different FDA-approved therapy based on the molecular characteristics. And this is how is now in the first line, Dr. Ahmed, he's mentioned about what we have in the luxury in the first line chemotherapy for RAS mutation, left side or right side, and also if patient with RAS wild type, KRAS wild type, and then if it's BRAF mutations. Thank you.
And interesting, challenging cases really, and we are running out of time, so just we may give time for 2 or 3 questions. We have questions regarding what you mentioned about the cricket data. Do you think now that cricket data pushing away a little bit the third line and fourth line drugs TAS and regorafenib because of the excellent response rate based on the circulating tumor cells for cetuximab, for example, reaching up to 70% by the cricket trial? So do you think that we are pushing away the TAS and regorafenib from the third and fourth line and giving the priority for the re-challenge approach?
I can answer, Dr. Ahmed, Prof. Ahmed.
Yes, go ahead, Dr. Waleed.
I think Dr. Rahman, he can join us. I think that is not pushing away of the third line regorafenib. Still, there is regorafenib and TAS1 and 2, but meaning for highly selected patients. Every time we said the selected patients for those, and I think a liquid biopsy will help us a lot in this regard. The liquid biopsy for those patients who still KRAS wild type, and as described for those patients, cetuximab sensitive disease, then clone become insensitive, given break, and then become sensitive again. I think this is we are talking about very selected patients, but still the regorafenib and TAS1 is still in the third line. But also the re-challenge is we are doing that in clinical practice. You know, for a patient who have very good response to start with chemotherapy, cetuximab, good response, we have consideration of the progression-free survival, time of disease-free survival. Those is a lot of the factors is very important in selecting strategy of this, and also the liquid biopsy is really helpful in this regards.
Okay, Dr. Anas asking regarding the to highlight the segments of patient of RAS or BRAF right-sided in which cytoreductive is high priority goal. We may share with you and of course this is the decision of the tumor board and our friends in the surgical oncology team. They usually considering cytoreductive for patient mainly with peritoneal metastasis, with oligometastasis, and less without extra abdominal extensive lesions, and they have their own score, prognostic surgical score, and also the PCI also taken in consideration also for the best candidate of cytoreductive surgery. I don't know if any of our colleagues will add for this answer.
I think you are clear, Dr. Ahmed. I think that's very important criteria, and even the surgery, it is really selected one by one. Not every patient is going for surgery, as you mentioned, and this is depend on a lot of factors. We have the resectability, the tumor burden, the age of the patients, as you mentioned, the score system for the patient. We know the right side is a poor disease to start with, but we tried our best in those patients as much we can.
Okay, there is a question from Dr. Zubair Hassan to Dr. Amjad. What do you prefer for patient with RAS BRAF wild who progress after second line BIF to re-challenge with the cetuximab or to start Rigora TAS? This is what we discussed in the first question. Yes, Dr. Amjad.
Actually, the thing is that it depends on multiple characteristics. For example, if the patient is having a RAS and BRAF wild type tumor, and if the patient best after receiving bevacizumab chemotherapy, then one option based on 18147, that bevacizumab containing chemo regimen with alternate chemotherapy, that is if patient received in the first line FOLFOX, bevacizumab may be combined with FOLFIRI and vice versa, and it has shown that this is a good option to continue with. Otherwise, if the patient has very rapid, some patients who have very rapid progression on bevacizumab, whether you want to have a good control of tumor shrinkage, in that scenario, you may prefer in the second line cetuximab. based chemotherapy rather than continuing bevacizumab, because as we have known and seen that cetuximab leads to greater tumor shrinkage in the short term period. And if in the later line treatment, if then patient already received cetuximab in the second line or in the first line, then regarding reach challenge, as Dr. Waleed mentioned, there are many factors to consider. First of all, cricket trial is a small study. Number two, it is a phase 2 single arm without any comparative arm, and that also is seen, the benefit was seen mostly in those patients in which the record biopsy showed that the tumor was RAS wild type. So in this subset of patients, if the patient is having and also the duration of anti-EGFR free duration, that when the patient received first line or second line anti-EGFR, and then the patient was about 5 to 6 months without anti-EGFR, then you can think about the challenge of with cetuximab. So, and also these are the early data, only phase 2 data. There are 4 studies undergoing, and the results of this 4 will establish the role of cetuximab re-challenge in better way, and they will also establish the role of liquid biopsy in this setting, that rather the liquid biopsy and those tumors who are RAS wild type, these are the only one who will benefit with re-challenge, or all patients will benefit. So for the time being, it is a preliminary data, but cetuximab re-challenge has shown benefit in those patients who have responded well in the first line, and then there was anti-EGFR free interval of 4 or 5 months or more, and then the re-challenge may achieve a good results. And these can be compared to results of regorafenib or TAS-102, and as I have shown that cross-trial comparisons are not good, but re-challenge a small study as to cricket trial shows better results in terms of overall response rate, or objective response rate, overall survival, and progression-free survival compared to the other 2 drugs. But the data is only based on phase 2 study, and further studies are needed, and far 4 is underway, which may give answer to these questions.
There is another question regarding based on the data from Anchor and Beacon trials, what is the best use of cetuximab plus encorafenib in patient with BRAF mutation, RAS wild in the first line or in the second line? I think the answer is straightforward. Now we have the data from regarding only phase 3 trial from the TRIBE data, which FOLFOXIRI PIF, while what we have in the Anchor trial, it is phase 2 single arm, and this is in the second setting. So the strong data which we have is mainly from the second line Beacon trial. So it is in the second line, not on the first line, based on the strength of the evidence. What do you think, our colleagues?
Yeah, I agree with you, Dr. Prof. Ahmed. This is the evidence, and the study is well designed in the second line setting, in the BRAF mutant disease. For a first line, we use the combination chemotherapy. If patient is very fit patient, we might try the triplet plus bevacizumab, but we know the BRAF is one of the poor prognostic. For a first line, still the chemotherapy plus bev. Only the trial is approved for the second line. There is now ongoing the phase 3 study on the first line, but it's not yet. Might be in the ASCO this year or the coming years.
The last question directed to Dr. Waleed regarding this maybe pseudo-adjuvant in his case. Would you recommend the use of cetuximab in the direct adjuvant setting for patients who present with a resectable disease with a high risk of recurrence like right-sided tumors? So regarding maybe the cetuximab in the adjuvant setting.
No. First of all, for cetuximab in the adjuvant setting, there is no evidence for that at all. For adjuvant setting, no. for a patient with clearly resectable disease, right side resectable, we prefer to go for resectability first and then chemotherapy. Yes, but for unresectability, this is different issue. Yeah, but adjuvant setting of cetuximab, there is no is negative study. There is no any adjuvant for both bevacizumab or anti-EGFR.
I think if there is no more question, we can conclude our meeting. We're thanking the speakers, Dr. Amjad, Dr. Waleed, for the nice talks, and thanking Merck and Muhammad Auda specifically for the great effort and for encouraging